Hi everyone, Professor Widener here. We're going to review the lecture and PowerPoint for Chapter 1, Making the Case for Evidence-Based Practice and Cultivating a Spirit of Inquiry. The thing that I'd like you to think about that the public has found quite frustrating through the course of the COVID pandemic is that because we had no research or no prior knowledge of this specific virus, science has been unfolding in front of us, and we made our best guesses at the beginning of the pandemic with what we could do. We weren't exactly sure, but then as evidence and case reports have come around over the course of the last almost year now, protocols have changed, treatment protocols have been initiated, and even what we've been required to do in public has changed. But again, it's kind of a cool time to see science unfolding in front of us and how the evidence has changed what we do on a national and global level. And if you keep COVID in mind and how the past year has changed, and even in your practice at the hospital or wherever you are in urgent care, how things have changed and how they've been evolved by the evidence that we've obtained over the last year since we've learned more about COVID, I think that it'll make it a little bit more realistic to you and interesting. So there is a process for evidence-based practice methodology, and it includes 3 parts. The first thing that it includes is the external evidence from research. We're going to look for evidence-based theories and opinions from leaders and expert panels. Then there will also be, particularly in nursing, I think that this is important, that we are allowed to include our clinical expertise, because there are components of things that we can't always account for, like physical assessment and patient assessment and evaluation, what resources you have available. Obviously you have different resources if you're at a small rural hospital than at a large city hospital. And so that clinical expertise kind of includes those things that are a little more fluid. And then the last thing that is important in making evidence-based decisions is patient preference and values. So we're going to work through this whole process over the course of the semester. And there are 7 different steps to that. There are a few types of evidence that we use in evidence-based practice. There are such things as evidence generated through rigorous research, and I think that that's the important thing to understand just here at the beginning. You are either in an MSN program or a DMP program, and we will not be conducting research. What we are doing at the level of the DMP or at the MSN level, we're evaluating research and we're deciding if that should be used in our practice or not. And at the DMP level, we're using evidence to make systemic changes that will hopefully improve outcomes of a certain population. We are using other people's evidence, but this is to help bridge the gap between the research and practice. So it's actually a very important role to understand these. There are such things as systematic reviews, and what they are is a collection of articles where people review anywhere. The numbers can be variable. I've seen systemic reviews that are like 10 articles that are reviewed, or I've seen up to 30. It just really depends on the topic and how much is available. But systemic reviews are very good evidence because, again, they're reviewing lots of different sources. There are evidence-based theories, which we will be learning more about. There are also national benchmarks, and there are opinions of leaders and expert panels. So for instance, think of like JNC 8 and the hypertension guidelines. Those are expert panel opinions. When we look at the type of internal evidence that we use for evidence-based practice, we use such things as practice initiatives. So maybe you're working in a community health center that wants to improve the care of their patients to make sure they get their yearly screenings, like for their eyes and their feet. That could become something where you implement a guideline to help improve that process, and you would use evidence-based quality improvement projects. Another internal evidence would be patient assessment or evaluations, and again, the resources you have in your own organization. So question number 1, is the following statement true or false? Finding a quasi-experimental research study that tests a protocol for the frequency of turning for immobile patients published in a peer-reviewed journal is an example of external evidence. And that is true because external evidence is research articles in peer-reviewed journals, and it is important that they are peer-reviewed journals. We're going to talk a little bit more about the difference between evidence-based practice, research, and quality improvement. They all have some nuances that make them a little bit different, but evidence-based practice is a decision-making process. It is based on a body of evidence that has been identified and critically appraised and synthesized. So that means that you've identified a problem, you've looked at the research related to it, you've decided. Critically appraising means you decide that's good or bad research, and then you've put it together, and then with all that combined, you generate new knowledge about the practice through implementation of evidence-based recommendations. It is not generalizable, but it is rather transferable. So if someone had specifically, again, they wanted to improve the outcomes of their patients, getting their yearly eye check and foot check, let's say another practice has that same issue, they could take what you've done and transfer it to their practice. Sometimes you do need IRB approval, and that means that if you're going to use human subjects, sometimes you need to go to the institutional review board, and that does vary from organization to organization. And those of you who are in the DMP program, when you implement your project, depending on the use of human subjects, you will be required to go to the IRB as well, and you'll learn more about that. Research tests the hypothesis. So in that same problem, the researcher still has to think of a question. So the question could say, I think that giving the diabetic patients a phone call once a month to remind them to do their eye checks and their foot checks would help them improve compliance with that. They have, obviously that's important, an important topic, but they're going to test the hypothesis. They have done a review of the literature, they've identified a gap, and they're going to test what they think and see if it works. It may work or it may not work, but they're going to decide that through their research. And the point of research is to generate new knowledge, to fill a knowledge gap, and the results are generalizable, and they do require IRB approval. Quality improvement, which is, if you think about, you have quality improvement at your hospital and they've, do things or change processes within the organization. They use a systemic process as well. They look at certain structures and processes that are impeding quality and safety. And then they use the internal review of the evidence. So let's say they want to review medication errors. They look at all the medication errors and they identify and track the trends. And then based on that, they make some decisions as to how to go forward. The results are not generalizable because they're specifically for that institution that they're being developed for, and they are not overseen by an institutional review board. So question number 2, which of the following involves bringing a body of evidence together with clinical expertise and patient preference and values to identify best practice? And that is our friend, evidence-based practice. That is exactly the definition. And I want you to remember those components as we're moving through. So what we have to do now is look at how all this merges together. And this is the art and the science of improving patient outcomes that comes together to improve quality care and all these different things that we've talked about. This is a figure to depict that is exceptionally helpful, and we're going to work through all that a little bit more. So we used to use the triple arm, but now we use the quadruple arm. There is if you are looking for more specific information, you can go to that website for the Institute of Healthcare Improvement. But what we want to do now is improve patient experience, improve outcomes. We want to reduce cost, and we want it to be organization driven, and that often includes things as joy in work. We want people to enjoy work more, enjoy what they're doing, and evidence-based practice helps us meet this arm. We all know, again, thinking of the cost reduction, we all know that healthcare is extremely expensive for our company, and the more we can encourage evidence-based practice in doing things that actually help patients and maximizing their health and their experiences should improve their overall health as well. So some of these key initiatives to advance evidence-based practice have come from the Institute of Medicine, and they have put forth that by 2020, 90% of clinical decisions will be supported by evidence. It was not always the case that evidence was used to make clinical decisions. Sometimes we do things because that's the way we've always done them, and it may or may not be helping our patients. But again, in order to meet those objectives that we just talked about, clinical decisions need to be evidence-based. Some of these key initiatives include the United States Preventative Task Force. If you'll notice, they're the ones that make recommendations as to how frequently we need to get our mammograms and our PAPs, and for the men, how often they need to get their PSA checked, and for everyone over 50, they recommend a colonoscopy. There is also a community service task force. There's Patient-Centered Outcomes Research Institute, the ANCC Magnet Designation and Pathways to Excellence, and then there is the Helen Flood Health Trust National Institute for Evidence-Based Practice in Nursing and Healthcare. These are all places where you can find more specific information to guide your practice. Question number 3, is the following statement true or false? Although organizational culture and context are important, they are not necessary for evidence-based practice to be implemented and sustained in an organization. True or false? As you're going to guess, that's false. A culture and an environment must be made within an organization for evidence-based practice to be implemented and sustained. We have our own locally here in northeastern Pennsylvania, we have the Geisinger system, and that's one of the ways that they've really found to thrive is by following the evidence-based practice protocol. I know Geisinger has its minuses, but again, they really stick to that evidence-based practice protocol, and I think more and more it's becoming common practice. And again, if you think about coronavirus over this past year, we've all had to become accepting of evidence-based practice, because that's really case reports change. That's what we've had to do to develop new protocols on a virus that we didn't know existed just a little over a year ago. So these are the 7 steps that make up evidence-based practice, and I'm going to go through the ones that we will go through in Nursing 616, and then you will move on in your capstone courses, whether MSN or DMP, to complete the steps. The first thing we're going to do, and that's kind of what we're doing this week, is developing the spirit of inquiry within the environment. Like, why is this important to you and your practice? The next question that we're going to be working on over the next 2 weeks is asking the burning clinical question in a PICO format. I want you to start thinking about what is a problem you've seen either in your practice or at your clinical setting or an urgent care, wherever it is you've seen a problem that you think you would like to address by learning more about. When it says a burning clinical question, it definitely should be something that you're interested in, but remember, you're not going to cure cancer. We're looking for everyday practical problems that can be answered. And this does not have to be your life's work, whether you're in the MS science side or the DMP side. The most important thing to know is that we're teaching you a process. And although it may not be something you're super interested in, but it's something that there's lots of information on, and it's a relevant primary care topic, it may be something good to move forward with. After we have our question, then we're going to search for and collect the best evidence using, sorry about that ding, using literature reviews, and that's where our embedded librarian will be helping us. The third step is going to be to critically appraise the evidence. That means we have to refresh ourselves on some research terminology and statistical testing terminology, and then there's a protocol to how you critically appraise different types of articles, and we're gonna learn how to do that because that's going to be important to decide if what the article is telling you is useful or not. The last step we'll complete in 616 is we're going to integrate that best practice with your clinical expertise and your patient preferences and values in making practice decisions or changes. When you move on to step 5 and 6, they'll be done in the capstones. For the MSN students, you'll refine your PICO and get it into talk about some of the information that you've learned. If you're in your DMP, you'll actually implement your project and then talk about the outcomes and disseminate the information. True or false? According to our textbook, there are 6 steps to the evidence-based practice process. False. Initially, there were 6 steps, but they added the 7th step after research supported that there has to be an organizational culture of evidence-based practice and implementation, and that's actually what Chapter 13 talks about. These steps have to be implemented in sequence and rigorously engaged to accomplish the end goal of improving patient outcomes, system outcomes, and provider outcomes. So you have to lay the groundwork before you jump in and decide you're going to change everything. And you all know, if you think about your place of employment, that if somebody just came in and said, okay, this is what we're going to do, which is completely opposite of what you've done forever, that is probably not going to go over very well. So following the steps and laying the groundwork is very important. Some of the barriers to evidence-based practice and some of the things that help us are going to be within healthcare institutions and settings where care is provided. Both barriers and facilitators exist that influence the uptake and sustainability of evidence-based practice. What that means is that there's going to be some good things and some bad things within different organizations that are going to support the use of evidence-based practice. And each organization is going to be a little bit different, and that's why it's important to think about those things. Practitioners must learn how to overcome these barriers and leverage facilitators in order to implement evidence-based practice. I can tell you that I've worked locally at Wayne Memorial Hospital since 2009 as a hospitalist nurse practitioner, and I continue to do so today on a per diem basis. And changing practices that have been in place for a long time are very difficult. I was the first nurse practitioner in the hospital, and initially they did not trust me. But with overcoming the barriers and gaining confidence, I got to do things more independently, like place orders and do stress tests and different things like that. So it's the same kind of thing that you need to figure out what your barriers are going to be and overcome them. You're also going to need to decide how to do that assessment on an organizational level. Some examples of barriers can include lack of administrative or management support. There can be some resistance to change. People may just not understand it. They may have misperceptions or negative attitudes about it. There may be people who have went through NP programs or have been in practice for a long time. They may just not understand it or have that skill. There's also the time factor and lack of resources. Right now, we're in, even prior to the pandemic, there was a lack of time and resources, but now I think there are more, it's even been magnified. And there's also a lack of evidence-based practice mentors. Strategies you can use to overcome these include having a clear philosophy and organizational vision. You can develop a strategic plan to create that culture and environment. You can dispel any misconceptions about evidence-based. You can teach the basics of evidence-based practice. You can encourage questions about what is currently being used in clinical practice and develop evidence-based practice mentors. Examples of things that can be done are support and encouragement from the management. Again, develop these mentors, implement evidence-based policies and protocols, evidence-based policy education, support evidence-based practice into healthcare curriculum, which is why we're here, and teach you about the proper tools and possibly even have an evidence-based practice council wherever you work. The possibilities are really endless, but there are definitely some barriers to overcome, but it can also be very exciting to make some changes. A few years ago, we had a problem at Wayne Memorial where we were having a lot of urinary tract infections after someone had a catheter. So we wanted to find out why. We weren't exactly sure why, but what we did was, in speaking to some of the providers didn't even realize that the patient still had catheters in. So there was a lack of just kind of forgetting that they were there. And if the provider forgets, the nurse doesn't talk about it, everyone is busy moving around, the patient can just have a catheter for multiple days and not realize it. So what we did was we added an assessment to the provider's progress notes where they had to document if the patient had a catheter or not. And it was starred, so they had to check it yes or no before they moved on. So every day that was checked, and then the data was pulled by the nursing supervisor. And as a result of that, just education of the providers being more aware, urinary tract infections went down. The next thing we did was we gathered some data, and then we instituted a nurse-driven catheter removal protocol. Now there are conditions under which the nurses can remove those catheters in case it's time or they've been forgotten about, although that has happened less. Obviously, someone who's had a catheter forever, you're not going to remove that, but someone who's a post-op, they'll have automatic catheter removal orders put in on their post-op orders. So really it was just more educating and implementing different protocols that gave the nurses increased flexibility, and our outcomes improved with urinary tract infections. And that worked out good for the patients first and foremost because they were getting less infections. And number two, healthcare acquired infections became part of our repayments at the hospitals, so they did not pay. Hospitals were not getting reimbursed anymore for these infections. So on top of improving patient outcomes, it improved hospital outcomes and saved them some money on healthcare as well. All right, final question. Evidence-based practice is identified as a core value in our organization's new strategic plan. This plan includes making sure all policies are supported by evidence within 3 years. In order to accomplish this, units must begin hosting unit-based journal clubs from noon to 1 once a week to teach advanced critical appraisal skills. Staff are now permitted to attend if census and staffing ratios allow. What are the following barriers to the above scenario? Well, let's look at all these. Having a strategic plan, well, that's a good thing, and that shouldn't really be a barrier. The plan is to making sure all policies and procedures are supported by evidence within 3 years. Well, again, that seems reasonable as well. Hosting unit-based journal clubs, again, that sounds good. That sounds good as well. But the problem is D, the timing and stipulations for attendance of the unit-based journal clubs are very hard. We all know that from 12 to 1 to take an hour off the floor is probably not possible in most cases. And depending on census and staffing ratios, I would bet 99% of the time you're not going to get to the journal club. So it would be your job then to figure out a different way to disseminate that information to the staff that needed to learn it to overcome that barrier. So thank you for listening. And if you've gone through here and you have any questions, please just let me know. Take care.